I'm Dr. Marsha Sonaty.
And I'm Dr. Caleb Moore.
And this is
the Free Smiles Podcast.
We can talk about a case that I inherited. It's an all-on-X case.
What does all-on-X mean?
What is it? So all-on-X is, well, it started as being called all-on-4. So that was coined by a procedure where you have like a full arch rehabilitation, meaning that you remove or already have removed, or someone's going from a dentulous to wanting a fixed arch. I mean, that's an implant supported prosthetic that doesn't get removed. It's fixed in place. All-on-X stemmed from that in the sense of it doesn't have to be necessarily 4 implants. It can be 6 implants. It can be 8 implants. It can be 5 implants, depending on the AP spread and what you need. So these procedures, they are a big deal. I mean, I think any patient I'm talking to about doing a full mouth, any kind of full mouth rehabilitation, if it's changing their video, crowning, loss of tooth structure, having to do multiple restorations, and then going into someone who literally we're either compromised on the periodontal side of things, or we don't have the support for restorations anymore, or we have so much decay on teeth that are we really looking at doing like crowns on every tooth, or crown veneer combinations, or whatever that may be needed for that person. And a lot of times what we can do with an all-on-X case is actually almost combine in some of the costs to that and making it a little bit more efficient for patients to do an all-on-X case, because you're kind of absorbing a lot of time that you're spending on doing a full mouth rehabilitation. So there's like kind of pros and cons and ways you can discuss these with patients or have that as an option. But I think being prepared is the most important thing, because if you're not, then you probably shouldn't be doing the case.
Exactly. I think when people think of these cases, they think they need to go to an oral surgeon. So I would like for you to give everyone some background on, your education, your knowledge on these procedures. And I know that you weren't necessarily placing on this case, maybe you were restoring, but what have you set yourself up for success in these cases? What have you done?
Yeah, so I think even if you are just someone who is doing the restorative or the prosthetic side of this, I do encourage you to go to a surgical course, because you need to be able to direct the ship in a sense to be prosthetically driven. We always say, like, now that as we learn more and more about implants over the years, everything we do is prosthetically driven. But there is no room for error on the prosthetic side for these cases. Like, you cannot send this to an oral surgeon if they don't have the right guidelines and the right mindset and the right training on how to do these cases. Because if you get back, I mean, essentially what I'm dealing with right now is a case that was, I would say, at some point they tried to think it was prosthetically driven. And we'll talk a little bit about like the analog planning side of that versus the digital workflow. I think it makes it a little bit more predictable. But if we don't have the knowledge of that going into it, so what I did out of school was I took a few different arch courses. The 2 main ones, one was down in Brazil. So actually going there, doing the surgeries, spending essentially a whole week doing the planning, like from start to finish. Like, you're in the classroom learning, but you're also doing like patient care, taking out all the teeth, taking out old implants, planning things with your not digital, but sometimes it's digital. Sometimes you have like your CPCT and your scans. Down there, it's more analog, meaning that you're taking things physically, like without having like a 3D imaging system. And then you're planning it that way, and then having to kind of adjust a little bit more to what happens when surgery day happens. So the thing to know is, surgery day, you can have all the plans in place, and then you find out, hey, the bone type in this spot that we planned this 10 millimeter 3x7 implant, oh, the bone quality isn't great, or there's this lesion that's there, or this and this are happening, or we can't get bicortical stabilization, or whatever it may be, or we had to reduce bone. Like, there's so many things that can change and happen. But I think, so that course taught me a lot about, how to do things freehand. So we didn't have guides. We did nothing guided. We just kind of talked about where implants should go, how to look, how to lay a flap, open up, see where the sinus floor is, see how to angle into that, see what the nasal floor feels like if you're doing a bicortical stabilization that way. So I think just knowing that part of things and knowing how the surgical side goes, if I'm working with my surgeon that I have now in my office, I know how to direct that ship. Like I know how to say, hey, I need these implants to go here and here and here. And we're going to be on the same page because I know what she needs on her end, or he, if you're working with a gentleman. But in my case, it's a female. I know what she needs on her side, and I know how to set up, because I'm doing all the coordination. As the general dentist, like you're coordinating your assisting team, you're coordinating your kind of office to schedule things and all that stuff. And you're also coordinating, like when I'm doing my surgical guide planning, and we are planning to do this guided, but knowing that you need to freehand or be able to pivot during that surgery, but having the guide as like your initial like pilot. I think of it as like a pilot start to things and to give you reference points. There's different ways you can get reference points. So that was one of my courses that we actually did together. And then the other course, I just did like a 2-day training more on like models, like a model kind of like surgical part of things. And then a lot of just single tooth implant courses just around that over the past couple of years. Yeah.
So you're saying your surgeon is embedded into your office. What do you feel are the advantages that come with that?
Yeah, so I think, well, especially because we are a very niche practice of like holistics and like biological dentistry, we have certain patients that really don't want to go outside of our office. Like they really want things to be done in-house with ozone and the right biologics and doing like ozone pre and post conditioning and things like that. So they really want things to be in-house. The other advantage to that is that I'm able to work with my surgeon day of surgery and pre-surgery and having the consultations together if we need to. And it's really just keeps everything flowing really well, because if there's a person that comes into me and they're like, hey, I'm thinking about this and this, I know I can get all the initial records that I need to. I can present the case to my surgeon and say, I think we need this, this, and this. She'll meet with that person or maybe have a phone call if they don't want to come back in again. And we're all going to be on the same page because, again, the ship's being directed by me. And I know we're going to need have everything that we need in that situation.
And I think what's really cool about that is the time that you have spent preparing for cases like these. This is changing somebody's life. You know, they're coming in, you're removing all of their teeth. It's invasive in the sense of you are removing their bone, right? And so you're the last stop in that, right? Restoring that, giving them back their smile. And in terms of what records do you need? What are you using to plan for their occlusion, their bite? How they feel when they leave for that day? How did you plan for that?
Yeah, so I have a different case that's coming up next month that we've been planning. And so if I'm handling a case from start to finish, what I need from that patient is not only like giving them all their options, giving them, hey, she essentially has like failing bridges in the posterior, kind of everything's falling apart. So we would need to do either 3 to 4 implant bridges or single implants, and pretty much restoring her entire posterior arch, and then giving her either veneers or something in the front. Or again, she decided to go through the all-on-X procedure in this case. So what I want from her is just going through all the options so she's comfortable. So giving her plenty of time to weigh the pros and the cons, especially for patients who are like what we call high C patients, meaning that they're very, they have a lot of questions. They really look into things. They're very analytical. So that kind of patient wants to know details, even if they don't even know what the answer means. They don't really need to know in their mind. They just need to know that there's all their answers to all their questions have been met. Another big part of that is the right proper consent forms. So me coming into my practice, it was really bringing in a lot of that knowledge of, not only just pre-surgery consent forms, but the proper ones are for those. Follow-up and warranty consents, like how many months we're checking certain things, what the patient is held accountable as far as after we do this final prosthetic, seeing them on a shorter recare basis to remove all the screws, take the prosthetic off, do follow-up x-rays, and to hold them accountable for that. Because if they fall off the radar for 5 years after their all-on-X is placed, and then they come back and something's broken, that is something that could have been, we could have noticed. We could have noticed an early infection. We could have done this or that. We could have done bone grafting around an implant or whatever it may be, which is also the pro of having a surgeon, is just being like, hey, if this happens, I know I can send her to my periodontist in-house to have anything that's just starting. But obviously we want to start from a good foundation and set that up. We want full arch digital impressions. So that's with the Trios is great. If you have other scanning in your office. Just some kind of digital impression is key, I think, for especially the digital workflow. And then full face photos. So you want full face photos of a patient, hopefully from the same distance for each of them. So as the lab is designing, and I'm working with a digital workflow for this next one, they need to be able to load that patient into Exocad or whatever digital system they're using. Use your STL files, superimpose it, so then you have the prosthetic and the smile driven into that patient's profile. Not, hey, I think this is where the teeth should go, but then you put it into a patient and you're giving them either a more gummy smile, not a right smile arc, a reverse smile arc, something like that. Which actually this patient that I'm seeing is starting off with a reverse smile. So we're trying to correct that with the surgery as well. So, yeah.
When you're doing the full face photos, the one thing that I think is really important is the Duchenne. Or sometimes, I learned from a local oral surgeon that you can take a video of them just laughing or smiling, tell them a joke. I'm terrible at jokes. I don't like to give dad jokes.
I feel like you're better than you think you are.
I don't know.
And this room is a strobe light again.
I know. But so, having that smile or the laugh, because the smile line is crucial, right? Or the interface or the interface of the prosthetic with the gum tissue. So I want to walk through, after you captured all the data, you took your STL files, you have the photos,
CBCT also.
CBCT, and you're communicating with your periodontist. What was the workflow like with the lab? What was that communication like?
Yeah, so the case that I inherited started as an analog workflow, and now I'm converting it to digital. So if I'm starting from start to finish, what I'm doing is I'm communicating with my lab and sending them all that information. So I'm sending them the CBCT files, I'm sending them all the face photos, and there's like 4 to 6 different ones that we communicate with them. And then what I want out of the case and all the STL files, the initial kind of bite record, so they can have all that compilation to not have things printed, but having the initial records to line things up properly. So when I'm sending them day of surgery scans and imaging, they can kind of use those initial records, compile everything on top of each other, and it's just giving them more data points to then set things on top of each other on the digital side. So my communication with them is getting all that information, planning the day of surgery. So the lab that I'm now working with, they are technically out of state, but they have an in-state rep that has the photogrammetry camera that he brings in.
Oh, nice.
So we're able to use their photogrammetry. So what photogrammetry is essentially taking multiple frames of photos, they overlap on each other, and it gives essentially like a 3D image of certain markers. And we're doing, what are they called? They're not like, they're scan bodies, but they're different than like a traditional scan body would be, if you will. So they're compiling that over with the tissue scan, with tissue markers. All that stuff is being kind of compiled on top, and that's again going kind of interfacing with the STL file. So we plan that with them to be their day of surgery, that their lab's ready to design during that time. So deciding like workflow as far as, okay, we're going to start the upper arch. We're going to have these markers in. We're going to do the tissue scan with the TADs in different places. So they have that as like a tissue reference with like palatal, sometimes retromolar pad TADs are put in, and then sometimes on like the facial aspect, depending on where, because your tissue is going to change. And that's where a lot of, I think, the digital workflow, if you don't have the proper landmarks of where tissue can be overlapped on each other on the files on the back end, is where things get kind of off. So you've had those in a proper place. You take a pre-scan, beginning of surgery, on surgery day with the TADs in, and then you're moving on to extraction of the teeth, placing your implants, making sure all your MUAs are in place. Then you're doing another scan. So you're doing your scan with your photogrammetry at that point for tooth implant angulation. So then they can now start fabricating your temps for your upper as you're starting to work on your lower.
So how long are they printing that?
They're printing it for us. So if you have your own printer in house, then you would they would just send you over the design, then you'd print it. So that's what Dr. Shore does. So he has a out-of-state lab design everything for us. They're based out of Utah. They just send him over everything. He's approving stuff like when he's in surgery, he's saying like, yes, getting his lab on the phone, saying, no, I want this or this.
Yep.
It's all very kind of like in a concert, kind of coordinated like that. And then he's printing. So he's having an assistant. He has a 3D printer doing that part of things. We don't have a 3D printer, so they will actually print for us as long as we have everything to them by a certain time, and then overnight everything, so I can seat that provisional prosthetic by the next afternoon.
I think that's incredible, though. I mean,
Yeah.
for me, after a surgery that's invasive, I think I would just want to go home and sleep.
Well, yeah,
anyways.
and that's the thing is like there's a lot of, I mean, part of the digital part is to make things more predictable,
Mhm.
because seeing how an analog workflow can just take up, there's just so much that you have to account for after surgery: bone reduction, changing of implants, positioning. So even if you're planning implants in a certain place, but then your MUA height's going to change based on what the bone type is. Once you get in there, your implants are going to change a little bit in position based on the kind of bone quality you have, buccolingually. Like, are you grafting, and then whatever. Like,
there's so many changes.
So analog to me is almost, it's almost like you're setting yourself up for more work to then provisionalize someone, not get them in the proper bite and occlusion from the beginning, and then you're having to re-provisionalize again, which is what I'm currently doing with that case that started as an analog from a different doctor. I'm re-provisionalizing him because he was put in, essentially he was like more class 3, almost end to end to start off with. So a case like that in the lab that designed everything with him previously kind of shoved him back, like brought his jaw back, not even just like bite wise, but brought him back into a class 1. And what happened over time, over those like 2 to 3 months, we know he's going to move anteriorly. He's only going to hit end to end again on that prosthetic, which is then a denture prosthetic. And then he ended up fracturing the front teeth off.
Yep.
So rescanning him, getting everything kind of digitalized, sending over that Friday, and then they're going to have me the new design tomorrow.
So what were and I know this is one of the challenges, but would you say that was the biggest challenge? What was the biggest challenge for you inheriting a case like this and trying to, just correct things that could be improved for his bite specifically? What would you say was the hardest part of that?
Yeah, I think the hardest part of any case is just kind of gaining a patient's confidence. First, because he's never met me before. So it's like, hey, he's like, hey, I feel uncomfortable. I can't bite. Like he's, I'm asking him like how he feels in his current, situation, my first day meeting him. And he's like, oh, I can't do this. I can't, like, whatever. I'm really uncomfortable. I want to be done. Like, I'm exhausted. And as someone new coming into him and saying, I want to make this right. I need to put you in a new set of temporaries. And I know that's not what he wants. No one wants to hear they need to be in a new temporary after being in that set of temporaries for 6 months.
Yeah. How did you determine where his jaw wanted to be?
So thankfully we did have a like an iTero scan, because the surgeon did take one to make like a surgical guide, like a basic surgical guide. So I was able to look at his pre-records a little bit. They didn't give me face photos, but I had a couple smile photos. And I saw where you can just look at his STL occlusion, like with an iTero, and see like he is end to end. So I saw that that's where he was. And then I saw where he was when I first met him 6 months later, which was in that same occlusion, but he was discluded from the posterior at that point. And I could see where they had to adjust the provisional so much that he was in a cant. So his upper arch was canted. His midline was off. Things were kind of sitting to the right in his, or left in his smile. And then the whole just like anterior, like rupture of like the front 4 teeth, like all those things, even before that happened, because actually that happened between meeting him and then setting up his appointment a week and a half later to re-provisionalize him. 2 days later, he fractured those front teeth. So I was like, in my head, I'm like, well, I'm glad that we talked about this. I'm glad that we're already like discussing that being the thing that we're doing next. And just getting him on board. Like after that happened and he came in the lab, did a repair, the previous lab, the analog lab that we had previously worked with for that, they fixed it for the time being. But I kind of talked to him that day. I was like, I really just want to make sure that you understand that I really want to make you new. And I think he like understood at that point why I wanted to do that, because once we go to zirconia,
Yeah.
Once we go to a final prosthetic, if we don't get your bite perfect, that's not, oh, let's just kind of patch some teeth back together or whatever, like we do with like a denture. It's remaking a whole prosthetic. That's not a simple thing for anyone, to do. And then there's implant complications or bite relationship or jaw relationship. So I think the hardest part of the whole thing is just gaining patient trust if things aren't going smoothly. And he was a tough case. I think from the beginning, just from the surgical side of things. So
you won over his confidence, which is huge. That's a big thing to do. And how are you setting expectations with him moving forward? What are you expecting from this temporization process? How long is he going to be in that temp? And then what's the process look like transitioning into his final prosthesis?
Yep. So I was realistic. I said, I want you in these temporaries. I mean, the low end of that will be at least a few weeks. The high end of that might be a month or two. And if we don't love the way, I pretty much told him, I want you to feel like you're in finals, but still have some restrictions with diet. Like I want you to feel like you can chew, your jaw feels comfortable. You're not contracting your muscles in a funny way. You're not trying to like pull back to get your back teeth to touch or anything. Like I want you to feel that way. And then we are ready for finals. I'm like, until you feel that way, we are not moving into finals. I'm like, it's never going to be like how your teeth felt. Like it'll be different, but it shouldn't feel like it does now.
Well, what I love about what you just said was you didn't give him a time frame, because sometimes it's easy to say you're going to be in this for 4 months. They want to know, and it's like, well, this could be the standard. Like maybe 3 to 4 months is the standard, or 1 to 2 weeks. But your case is unique. You are unique. There shouldn't be a standard for this. So I love that you gave him a reference of, when you feel this way, that's when we know that we're ready.
Yeah.
So that's awesome.
And hopefully that's a couple weeks later.
Yeah.
But
hopefully.
You never know. I mean, when I uncovered I took off his prosthetic, when I uncovered everything, I mean, a lot of like the MUAs were kind of buried in tissue. So I had to kind of expose them again. I had to numb him that day. I had to, use a tissue punch or a scalpel to then open up, it wasn't, and his lower wasn't a better positioning tissue wise. I just think the amount of just fibrous tissue that was kind of there and how deep they had to go with certain implants and positioning, implant type selection played a part in like MUA placement as well. So there are certain implant types and brands that you only have so many options of placement for your MUAs. The Straumann, so the BLCs, and then the Neodent line, the GM line is I think a lot of doctors go to that for their All-on-X because it has a hexagonal interface and everything is interchangeable with other implants. Not even that like they actually were Straumann implants, but a different line of their implants that had a square interface. So if you think about that, you only have 4 options to then put your MUA angulation, and then that makes prosthetic work more of a nightmare and more of a surgical nightmare too, because then you have to move your implant that much more to get that angulation proper.
Wow.
Yeah.
But you managed it.
We managed it. So yeah, that's why you need to know your surgical side of things, because
exactly
you want the right implants to be placed, but also the right components that then fit with your prosthetic.
So when you deliver the final prosthetic for this, I mean, we're talking planning for surgery, ordering all of the parts, surgery day, temp process. The patients need to know from the beginning, like this is going to be a significant amount of time. This is an investment, because I think a lot of people, when they think of, well, I can get teeth in a day and I really don't want to spend a lot of money, or why am I spending so much money for this? There's a lot of work that goes into it on the planning side, surgically and restoratively. But then after that, there needs to be follow-up. So what are you recommending for patients who have these types of prosthetics? I mean, are they your patients for life? What is the follow-up on that?
Well, I think any of these patients are always your patients for life. Once you start getting into these, you have to know how to handle anything that could go wrong. So the biggest thing is, even like a smile in a day isn't like a final smile in a day. I think that's like a common misconception. Like, yes, you can print day of, you can seat within 24 hours. Like that's the goal, is to get someone provisionalized, because you want someone to start kind of feeling what the final is going to be like in that healing process. You want them to see how their bite is. You want them to see how the smile is, all that stuff. So the smile on a day part, even if you're seating that day, there's always like a 24-hour follow-up after any provisional seating.
Yep.
So you're, having them kind of lock it in. And a lot of times if we're doing same seat date, like what Dr. Alex does in Chicago, when he's provisionalizing day of, he's doing his adjustments on his bite and everything very well. Like he does a great job when someone's like under anesthesia, obviously getting their bite checked. Is obviously the patient's not doing anything for you. You're trying to manipulate them as you're trying to get that prosthetic seated. But he does a 24-hour check. So when you see provisional 24-hour check, you see them a couple weeks later for any suture removal. And then after that, it's usually, I would say, like about 3 months of a follow-up, depending on the patient. Like for the patient that I just re-provisionalized, I'll probably see him obviously sooner. Like I'm going to provisionalize him, see him for his 24-hour check, and then we'll probably do a week or two, something like that, maybe see kind of how we are from there, and where he feels, because we're going to kind of dial that in a little bit closer. But someone who you see them 24 hours, their bite looks good, they're doing that, it's probably fine to have them back within 2 to 3 months just to check, do another CBCT, check bone healing, check all that stuff out. And then after that, it's really depending on the bone type. So day of surgery determines torque values, all that stuff. So if you have, your collective torque value of like 120, which is kind of like your standard, but say you're sub that in certain areas, maybe you want to give that more time. Maybe you want to be provisionalizing for more like a 6-month period for someone who's more like a type 4 bone. For someone who's like in a FP1, they have like great bone type 1 and type 2, you can probably move to a final prosthetic probably sooner than that. But I think that's why that 24-hour check is really important, because you're kind of going over those things with that patient. Like they're no longer under anesthesia, they're no longer wonky, they're kind of feeling themselves again. And you kind of do a little like report, like this is how the surgery went, this is how we place things, we had to do this and this because this happened. We end up having to place 6 implants instead of 4. We end up having to place 5 instead of 6 because this or this, you're giving that patient all of that information so they know, okay, this is what actually happened. I'm not going to expect X, Y, Z. So for the first year, your standard is usually every 3 months. They come in, you take out, you unscrew everything, take the prosthetic off, sometimes take x-rays, depending on, again, it all depends on what that surgery looked like and what their post-CBC looked like. But if they have pretty solid bone, you're just kind of cleaning around the implants, looking what their hygiene is, which is more important. So you take your prosthetic off and you have just stuff everywhere. You want to make sure that your prosthetic is designed properly to not capture things, but also that they are using their water pick. They are getting around there. They know how to do that stuff and they're not neglecting things. And that's usually for the first year. And then after that, if they're on a good thing, then, come in once, twice a year. And again, it depends on the person. If someone was like perio before, I probably would recommend seeing them closer. But a lot of times what people don't understand is like that part of it is on the patient. Like that's not part of the initial treatment plan for an all-on-X. That's like, this is maintenance. It's not like you go out and you buy a new Porsche and then you expect the dealership to then pay for your tire rotation and your new brakes that you need or whatever it may be. Because after you take the screws out, they say 2 to 3 times for most systems, you're supposed to be replacing those screw components as well, because over time you don't want to risk stripping a screw. You don't want to like taking them in and out and stuff like that. So there's replacement parts that you need as well, which I think is important to know, that even though an all-on-X is replacement of a full arch, nothing lasts forever. You know what I mean? Especially in the mouth, like you're using this to chew and eat on every single day, multiple times a day. Things are gonna, kind of stand the test of time a little bit, and you're gonna have to replace certain things.
It's wonderful.
Yeah.
Well, I'm proud of you.
Oh,
we took the course together.
I know.
And like now you're crushing it. Look at these cases.
Well, I don't know, crushing it, but I think the biggest thing is just being just almost like advocating for your own education in this, and I think the biggest thing is like finding doctors that they're already doing this. If it's I actually met with a local oral surgeon today. We had lunch. He's doing these cases. I'm going to learn his digital workflow.
Right.
Because everyone does things a little differently. So it's like, if someone's willing to be like, yeah, let's let's sit down, let's talk, let's get the rep in. Like if you can find someone who just likes to like teach people things and they genuinely are just like wanting to share information, you should be utilizing that.
Yeah, I agree.
And you should make yourself a person that people want to do these things with. Don't be a pain in the ass. Because there's people, I think, that go out of these courses and they're like, oh, well, I can, amazing, I can do this. It's like, well, we never practice dentistry on an island, like you always are going to need some kind of support. If it's, hey, I'm down this part, is my local someone, so I know they place these, like I need this, whatever it may be, like just having that kind of community of things and also trying to be as prepared as possible. Yeah. But I think just knowing that dentistry is just not practiced on an island, and just learn as much as you can. It
is. I 100% agree with that. It's community oriented, and finding your community is huge. And it typically involves people who have been through the stuff that you don't want to go through, right?
Exactly.
So thank you for being a part of everyone's community who's listening and for sharing your experience with these cases. And it was really helpful.
Awesome. Let me know if you need anything.
All right. We'll see you guys next week.
Bye. Thank you so much for listening. If you enjoyed this episode, please share it with a friend. Don't forget to leave us a comment, rate us, and subscribe so you never miss an episode. We appreciate your support and look forward to bringing you more great content.